This conference will now be recorded.
Good evening. It is Monday, November 21st, 2022. I'm Herb Geller, sitting in the chair here, moderating for the AnCan Advanced Prostate Cancer Discussion Group. And we want to thank our sponsors. And I'm going to let Rick tell us who our sponsors are because they seem to change momentarily.
Well, it's not that they're changing, but it's that time of year when we got a few coming out of the woodwork, which is a good thing for next year. But right now, for sure, our sponsors are Bayer and Pfizer, Foundation Medicine, Janssen. I think those are the ones that we have in the coffers, but we've got about 3 more that are talking to us, which is a good thing. Which is a very good thing. We don't have them sealed yet, but they're on the way. Oh, Novartis. Sorry, forgot to mention Novartis.
Okay, so we do have a bunch of sponsors, and we want to thank them for their sponsorship.
And can I just say, can I just add, for those of you who have any concern, all our sponsorships are non-branded, so we do not promote any drugs or protocols on behalf of anybody that sponsors us. And I will say that one company that last year refused to sponsor us because we wouldn't do that has come back to us and just offered us a sponsorship for next year on a non-branded basis. So that's a big win for us. We're really pleased about that.
Yes, it certainly is. Great. Okay, with that, we'll move on, and I will call on Al Latimer to give us an update.
Okay, here we go. Thank you. I get to be first. Unbelievable. Okay, so I started Taxotere last month. I had my second infusion a week ago, Tuesday. And the best part of it is my PSA went from 65 to 41 after the first treatment. I've had some side effects. It seems like the first 2 days I feel pretty good, and then I guess the steroids wear off and you feel like shit for a few days. The first time it was like 4 days, and the second time was 2 days. I had blood pressure problems the first time. The cardiologist changed the meds. That has not been a problem again. But my heart rate, my resting heart rate now is constantly between 95 and 100, as opposed to 75 to 80. And they don't seem to be terribly concerned. First time that lasted a week. Well, actually, I lasted almost 10 days last time. And it's still, my heart rate right now is 101. And I'm just sitting here doing nothing. So I guess that happens with this Taxotere. First time I had some diarrhea.
I don't remember.
Pardon?
Go ahead, I'm sorry.
I was going to say the last thing. I had some diarrhea the first time, and I took two Imodium as prescribed, and I was plugged up forever. And before I decided to take some stool softener, and that was bad. This time I had no nausea, no vomiting, no diarrhea. I had no nausea last time either. So that's kind of been my experience so far. And today I'm feeling better. Oh, the other thing is I have some snowfall.
Right.
So, I think everybody, my wife wants to know if anybody knows what that means.
Oh, yeah.
You all do.
Oh yeah. Well, we know it ain't snowing in Fort Lauderdale, so we can imagine.
Right.
Okay.
So how long
Right.
how much of that's going to come out, who knows, I guess, but it's still, I always had a lot of hair, so it's not gone yet.
Well, I can tell you what happened to me is it pretty well went out. Very little left, but as you can see, it recovers. And of course, Peter is a better example than I am.
You should expect to lose
So,
less than this, Al. Less than this, I think, is probably.
Listen, less than that. So what about facial hair? That seems to be going on strong.
That's the break.
no, that'll disappear too. No, that will, I mean, I basically stopped shaving. It really just went away. My beard just went away.
It might do a number on your fingernails and toenails too. They can turn black and go through all kinds of.
So that's something else I did. I got these slippers that I can use for my fingers and my toes to keep them cold. With ice, you know, they got ice packs in them. And they have a nice freezer at the clinic. So I have an extra set and I change it about halfway through. So we'll see if that has any effect. So far, I'm not really noticing anything with my fingers or toes. Oh, and I also had, thanks to you, Peter, I have the ice cap.
Good. That'll help.
You feel kind of funny with all that stuff on.
Yeah.
But
How are your blood counts?
the people at Sylvester Cancer Center, University of Miami, they've been very good to me. Got no complaints from that end. So that's my experience up to this point. And
How are your blood counts holding up, Al?
Well, they're off a little, but the doctor was not concerned. I actually have it right here. My white cells are fine. Red has dropped a little. It's went from 4.2 to 3.8. Hemoglobin went down a little. Hematocrit, I don't know how you say that one. That's down a little. But the doctor said
So what is your hematocrit?
It's 34.7.
Yeah, that's fine. That's all. It's fine.
It went from 38.3 before the first one to 34.7 before the second one. They do a dead blood draw before, lab test before I do the infusion.
Right. Right. So other questions? Any other questions about Al? I mean, it sounds, the PSA drop is good to hear. The fact that you're still, that you get knocked out right after, I don't think anybody would argue that that's unusual. I mean, to me, it was 3 days. I got my infusion on Tuesday. By Friday, I was out of it.
Yeah, that's the way it was. I had Tuesday infusion, Wednesday, Thursday, I felt okay. And I tried to do things because I knew what was coming. And then Friday and Saturday, I didn't feel like doing anything. And I pushed myself to at least go for a walk, but that was a struggle. But Sunday morning, I woke up and I felt much better.
Yeah, I think that's the way it's going to be. And you're going to get 6 cycles?
That's the plan. They're going to do some testing after number 4, which brings up another little issue. We have a cruise booked for December 31st that I would like to do, but it's right in, it interferes with infusion number 4. And I guess depending on what my PSA does, maybe the doctor will let me make it 4 weeks instead of 3 weeks this time.
Look, I don't think there'll be an issue. At least when I got mine, when I had something in the middle that I had to do, a week isn't going to make that big a difference. So
I
my
skipped the whole
expectation
cycle
is
during COVID. I skipped a whole 3-week cycle during COVID. Went fine.
So I think you're good. Go on the cruise and enjoy it.
So it's a New Year's cruise. So that we didn't do last year because of COVID. So anyway, haven't no final decision at the moment, but that's on the horizon.
Well, so far so good, Al.
Yeah.
So my blood pressure, after I changed the meds, my blood pressure has been fine. My blood pressure is fine, but my pulse is 100.
Yeah, so that's kind of a little inconsistent because I don't know what's driving your blood. What's driving your pulse should also be driving blood pressure.
Yeah.
So that's kind of unless your blood pressure's too low. What's your blood pressure?
Well, my blood pressure after the first infusion, it did get too low. It got down into the 80/55 or something.
Right. I mean, if you're getting low blood pressure, then your heart's going to want to work harder to pump the blood, and the only way it can do it is work faster.
But I'm looking at my recent blood pressures. Oh, they're not even trying to get a good example here. 114/76, 91.
Yeah, that should be fine.
109/66, 97. This morning it was 131/72, and my pulse was 890.
Huh. Well, I think you need to talk to your cardiologist.
Well, I guess I could send him another note. The oncologist was not concerned, but yeah, I can send him another note. He's responsive. So anyway,
Anybody else had Jack? Jack had something.
Yeah, I've had a lot of patients taking prednisone. They so frequently get tachycardias, and arrhythmias, tachycardias are not uncommon. I understand he's taking prednisone in addition to Taxotere. Is that correct?
I am on 5 milligrams of prednisone. Yes.
Is that new or something you've been on for a while?
No, it went back to the abiraterone, but they stopped the abiraterone and kept me on the prednisone.
Okay, well, that was just one thing I wanted to throw out. I didn't realize you've been on it for a while. Okay.
So you don't think that would have anything to do with it right now?
Especially that low dose. You're not taking usually you get a higher dose of steroids when you get your infusion.
So like I said last time, after 9 days or so, my pulse dropped back to a normal level. So I'm assuming that it's going to do that again. I guess my body's fighting the poison.
Well, I mean, it's going to happen. There's, you've got Taxol, your nerves are reacting because it goes to the nervous system as well, even though you don't want it to. So it's hard to predict.
I'd say, Al, also watch out when you get up suddenly, when you stand up from a sitting or lying position suddenly with a low blood pressure. Just make sure you don't get a little lightheaded.
Right. I experienced that when I was having low blood pressure, but it's been pretty normal now, and I haven't felt that at all.
Okay.
Since I changed the blood pressure meds.
Okay.
So anyway, thank you guys.
Well, we'll keep in touch. I mean, it's working. Let's just keep with it.
So, I can stand a few days, down days here, and, they're predictable, I guess. So, anyway, thank you.
Okay. Thanks, Al. Okay. Caller 05.
Yeah, it's caller 05 is John Kish, I think.
Again, he came back.
Yes, yeah. And John, I muted you before because we can hear you breathing into the phone all the time. So probably the best thing is if you can mute your phone until you want to talk, and then unmute if you want to talk, rather than us muting you. So thanks, we appreciate it.
Yeah. Thanks, John. Okay, Peter, what's up? You have the next hour.
I'll keep it brief, but it's an unusual story. So, actually, my information is probably very pertinent to two guys who aren't on tonight, Russ Strelo and Dr. Bob G in Philly. But I'll email them on my own just to update them about what's going on with me. So the short story is I'm back on Maui. I was in Minnesota for 4 months, in Minneapolis, under the care of Dr. Emmanuel Antanarakis, undergoing immunotherapy, Keytruda, which is a targeted therapy for my particular mismatched gene mutation. And I'm in a sweet spot for it. Just as background, I think you guys know I now have 3 medical oncologists working with me. Dr. Antanarakis, who's a GU med onc at the University of Minnesota in Minneapolis, and Dr. Mark Schultz, who I've been with for 8 years down at prostate oncology specialists in Southern California, and my local guy here, Dr. Ian Okazaki, who did my chemo 3 years ago. Anyway, short story is that while I was doing the Keytruda in Minneapolis, number 1 went fine. My PSA dropped after that, but then it went up to about 1 point something before I did number 2, and then it went up to 3 point something. No, 4.07 before I did number 3. And then I went up, did my blood test just before I came back here at the beginning of end of October, before I flew back to Maui. And my PSA had jumped up to 7.15. That doesn't sound much to some of you guys, but for me, who's been down around 1 or less for forever, because I keep an eye on it, it was significant. So every 3 weeks, it was doubling or more, jumping up 3 points or so. So Dr. Antanarakis felt, well, this isn't good. Maybe this Keytruda is not working for you. Let's pull the plug. So I did not do treatment number 4 in Minneapolis, and I went back to Maui with Antanarakis saying I should probably start olaparib here because I've got a genomic BRCA2 mutation. He thought maybe that was the way to go with a PARP inhibitor. So I come back here, and I had an appointment last Thursday, with my local guy, Dr. Okazaki, and I'm in treatment limbo. I mean, I haven't been on ADT for about 1.5 years. I've been off of Nubeqa, darolutamide, for 6 weeks now, and I haven't, I was just on Keytruda, and I've been off of that, after my 3rd treatment, which was about 6 weeks ago. So I go to do a blood test last Monday, and lo and behold, my PSA drops from 7 to 2. So I write to Dr. Antanarakis on the portal Monday night, and I say, hey, Dr. Antanarakis, looky here. I've got an appointment tomorrow at 5 o'clock your time in the afternoon to talk to Dr. Okazaki. And you want me to do olaparib, but Dr. Schultz, when I talked to him, said, oh, not so fast. Maybe the Keytruda is working. Maybe it's the dead cancer cells that are pushing your PSA up or whatever. I didn't understand his logic, but his thing was, oh, you're not so fast. You're in a sweet spot. I mean, there's no reason why Keytruda shouldn't be working for you. So I write to Antanarakis, and he writes me back when I wake up the next morning on Tuesday morning or Wednesday morning, whatever it was. And he says his actual words were, wow, that's unexpected and good news. And maybe you should start up Keytruda again. So that's exactly what I'm doing. So tomorrow I go for Keytruda number 4 here on Maui. Did a blood test today, which I'll do prior to each infusion, and I'll see where I go. I mean, to me, I'm a kind of a happy camper. I mean, none of us can be ecstatic about the fact that we're doing treatment, but our best hopes are sometimes in treatments. And so I'm hopeful, because this is the one therapy that I might get really good mileage out of. And, so I'm happy that the course is charted now, and I'll talk to Dr. Schultz next week and let him know what's going on. And that's my short story. So I'm a happy camper, and we'll see where we go and what the side effects are. But I'm glad that my PSA went down, and maybe immunotherapy seems to take some time to kick in, because it's stimulating your own body to fight this cancer, and that doesn't happen overnight. So the drug is actually stimulating your own T cells to fight this cancer, as far as I understand. I don't understand all the mechanics of it, but I'm willing to give it a go.
Huh. That's an interesting story, Peter.
Peter,
And
this
it
is
just
Al.
shows you really can't look at short-term trends.
Right?
Peter, Dr. A was surprised your PSA went down. He's done a lot of this, right?
He's done a lot of it, but there's not that many guys with prostate cancer with a mismatched gene, and we don't know if that's driving it, but it's more than likely.
Maybe Schultz has more experience with it than Dr. A.
Well, they both do. They both have experience, but whatever. It's yeah. I don't know. I don't know how to phrase that.
You're at the cutting edge.
So
Yeah.
I also thought you couldn't get Keytruda on Maui, but now you can.
Oh no, it's always been available. It's just I'm an odd duck. I mean, I don't think they do it for prostate cancer. It's not that many guys with prostate cancer that go through Keytruda. I think it's used for other cancers and stuff. So it is available. I knew it before I left that Keytruda was.
Excuse me, Peter. You said that you have a mismatched gene. Okay, explain that, please.
I don't know if I think Herb could probably explain it better. There's two major mutations in genes. One is the mismatch gene, which leads to Lynch syndrome, and there's about 6 genes that trigger that. Mine is MSH6. And the other one, I can't remember. There's another word for the BRCA mutation. There's another term for that. So it's not mismatch. It's something else.
Right. So Al, I mean, Jim, there are different ways in which DNA, when it's broken, gets repaired. And sometimes there's a mismatch in DNA, which means the bases at the end of the break don't match. And so you need a certain pathway to fix it. Other times you have a double strand break, and that requires a different pathway to fix it. And that's what Lynch syndrome gets involved in. So mismatch repair means that it doesn't repair DNA strand breaks. And so you get mutations. And so you can take advantage of that to kill the cell with Keytruda. You essentially say, don't fix it. It's called, it basically forces the cell to die, because you basically prevent the repair.
Okay, thank you very much.
So it's called, the term for it is synthetic lethality. It means you add a drug to add the synthetic pathway that produces lethality.
So
And there are many different pathways that can be attacked.
The other important point to note in Peter's case is not only does he have this mismatch repair, but he is also what's called microsatellite instability high, MSI high. And that, together with the mismatch repair, makes him a good candidate for the pembrolizumab.
Got it.
So I know this
Peter,
gets pretty sophisticated and complicated, and I'm trying to wrap my head around all this stuff too, but it's,
hey, look, you know, as I put in my introduction, Rick didn't talk about my introduction, but when we give Thanksgiving this year, when I give Thanksgiving this year, as much as I'm not in favor of big pharma, we have to give Thanksgiving to what they're producing for us.
right.
I mean, that is, and this, you know, and pembrolizumab, abiraterone, Pluvicto, they're all out of big pharma, and they're all moving us in a positive direction.
Right.
Okay,
Yeah,
Peter
Herb,
will be here eagerly. Yes.
I wanted to comment here because, I mean, Peter is a classic textbook example of the kind of person who should get pembrolizumab. So I'm really glad to see that it's finally turning around for him. But I did read an opinion piece, I think it was just a few days ago, where an oncologist was saying, I think it was titled something like Immunotherapy Imprecision. And he went on to say that we oncologists are proud of ourselves for saying that we practice precision oncology. He says, but in many cases, we really don't. And he said, in the example of immunotherapy, a lot of guys are getting immunotherapy who shouldn't be getting it. And even the ones who maybe should get it are getting a one size fits all dose. You know, there's no dose adjustment.
Right.
And you know, we could be causing unnecessary side effects as a result.
Yeah.
So, you know, I think you had some side effects with the first few infusions, right, Peter? So,
Oh, yeah. Even the last
yeah,
one.
so maybe have a if you get side effects, and I hope you don't, but if you do, maybe have a conversation with one of your 3 oncologists about a dose adjustment. For all we know, these you know, the pharmacology companies, the big pharma companies, they do their phase 1, 2, 3. They figure that we've got the right dose here, but they don't always have the right dose. Oftentimes they have a larger dose than what's necessary. And if maybe we can reduce the dose, reduce the side effects, but get equivalent efficacy. So yeah, just have that conversation.
I mean, the problem with that theory, Len, is, I mean, what they do in the phase 1 and phase 2, they basically go to the maximum tolerated dose, right? They're
Yeah,
looking at what they can push to get an effect that doesn't cause excessive side effects,
right.
right? And then for them to back down would require an enormous clinical trial, right? And to sort of adjust the dose,
Not necessarily. I
right? I
mean,
mean,
the docs have the flexibility to modulate the dose. Just like how many times have we heard guys say, "Oh, I was so tired on enzalutamide." Well, the doc said, "Why don't you just take half the dose?" And they do fine.
Mm.
So, you know, I think it's something worth discussing if it's an issue, if the side effects are an issue.
Right. It did come up in Minneapolis, because Dr. Schultz suggested, when I told him about my side effects, Schultz suggested going to half a dose. And I asked at the University of Minnesota, and they said, no, this is the dose. We don't go half doses. So I bit the bullet and I did it. But I could, you know, I'll see how I do with this here, and if I need to, I'll see if I can revisit that thing here. I don't know what they'll say here.
Yeah.
Mm.
Yeah, I mean, he's right in the sense that they don't have data to show that lowering the dose will be just as effective. That
Right.
doesn't mean that it's wrong. It just means they don't have data.
Right.
I mean, I was on a half
Right.
dose of darolutamide for about 8 months, and it didn't make any difference in my PSA. So,
I think it's all true, and I wish, obviously, dose adjustment, it has to be done on an individual basis, because nobody has the data.
right. All
Okay,
right, good
Peter,
luck,
anything
Peter.
else for us?
Just to comment on what Len was saying, you know, I was getting a lot of serious diarrhea side effects from full dose of darolutamide, and my doctor didn't, I just cut it in half. I mean, I didn't exactly get her approval. I just cut the dose in half myself, and then I told her about it, and at the same time, I mean, there was an advantage as I was stocking up on that very expensive medication. You have to make your own. I mean, I was thinking that the serious diarrhea, like probably I lost some of the value of the enhanced dose. I made the just, you said it has to be individual. It can be with the doctor's discussion, or in the case of something like where you have an option, you can do it yourself. You just do it. And because
So,
discuss it,
Larry,
but you, yeah.
Larry, we've had this discussion on here before. I mean,
Oh, all right.
everybody should do what they need to do. It's fine. But
Right.
we as moderators do not endorse you changing your medication dose without the knowledge of your doctor or telling them ex post. You just don't know. I mean, certain medicines you just cannot do that. It's going to have serious side effects. So our recommendation is that if you feel you need to change the dose as you did, run it past your doctor first and not after. But that doesn't mean to say you can do what Larry did and you get a good result. I mean, one medicine that occurs to me where you changing the dose can really help. There are gents on here taking metformin, and the standard dose of metformin is 1,000 milligrams, I think. And a lot of guys get stomach issues and diarrhea. And so it's pretty well accepted that you can cut that down to half, at least to begin with, and you get over it. And I think specifically of Jake, God rest his soul, because he was having those issues and he checked and he cut it down to half and he got over the issues. But I mean, I have to say, and I'll defer to the other moderators, but hopefully they'll endorse, we can't be changing our dose. I mean, Len didn't cut his dose of darolutamide down by a half without consulting Dr. O. So,
Yeah, I know I tend to agree with you not to give this as advice, but it made complete logical sense to me. And I actually told my doctor afterwards. I didn't ask her. I wasn't gonna, unless she said, oh no, you can't do that because blah, blah, blah. I find that more and more I am like taking control in the sense that I'm dictating what happens to me. I feel better about it in general, and I know it's not the standard of AnCan to give that advice, but at the same time, I think that we at AnCan, learn a lot and have to make decisions that may be decisions that we make as individuals that go a little bit outside of what a doctor may or may not want to do, and to get our information. And I don't know. I feel like more and more I am taking control, and I'm starting to see my doctor, as good as
I
she
mean,
is, and as
but I hear you,
I see
Larry.
her more as a gatekeeper than the person who controls me. She gives me advice, and then she's the
Larry, but I
gatekeeper.
think the issue really is the advice that Rick is giving, I think is correct, which is at least run it by the doc. You want to change the dose. It's an email saying, can we go to half a dose? And they're either going to say, okay, try it, or here's a reason why you shouldn't do it, right? It's one or the other. And
Yeah,
but at least you've got some endorsement rather than flying solo.
yeah. Well, I'm not exactly 100. I agree with you, but not 100%. Sometimes I think I'm flying solo to some extent. You
Well, then
take your
maybe
chance.
you need a better doc.
My doc is great for me. You mean find like in Len's case where he wanted to, as far as I know, when he wanted to stop Lupron, he had to and switch to add darolutamide. I mean, he had to change docs in order to follow that path. My doctor is not in favor of stopping Lupron, but I told her that I'm just not going to show up when the time comes that I want to stop it. And so she understands what I'm doing. She understands what I'm doing. And my plan is not to get into myself, to continue with the darolutamide dose. My PSA continues to drop. I'm going to stop the Lupron and see how it works, unless there's some great objection that she has that makes sense to me. I'm sorry to that.
Larry,
Like,
I just need to correct what you said. I did not change oncologist to when I dropped the Lupron.
oh,
I was with Dr. O before and after, and I did consult with him. So
all
I
right.
mean, what Rick is saying is, as moderators representing AnCan, we have to say,
Sure.
notify your doctor. Of course, obviously, you're an adult; you can make your own decisions, but that's the position we maintain. So
Yeah. Well, I
you do
understand
what you
that.
want. Yeah.
Thank you.
Okay.
Now, Herb, can I
So
make
Peter,
one other
we can
comment?
move on. Of
Herb, can I
course.
make one other quick comment?
Sure.
My mind goes back to there's not that many of us who have a genetic mutation driver in our cancer. Was it maybe 16% of us with prostate cancer, something like that? But to me, it speaks of this should be a no-brainer that everybody at their diagnosis should be screened for genetic mutation, because I in the back of my mind saying, if this works, why didn't I do it earlier? I mean, I've been through chemo and I've been through several kinds of radiation and this and that. Maybe this could have saved a hell of a lot of treatment deal if this is actually working, and the genetic screening pointed to this kind of therapy. So maybe that's the future, is just standard of care immediately at the same time you do a biopsy, put someone through the screening.
It is the standard of care.
Right.
Good.
Right. This is a big issue. Okay. It is the standard of care. We are well aware in the AnCan group it's the standard of care. But how many times do we come across medical oncologists, even GU medical oncologists, who don't order the profiling, even though they're supposed to order the profiling in advanced men? I mean, the NCCN guidelines are pretty clear on this. And that's why we so often say you got to go back to your doc and you got to go see, is there anything? Now, Peter, one thing that occurred to me in your own case, I was going to mention it and it went out my mind. You haven't been profiled in probably a couple of years now, since I think the time when you had those you had the mass in the peritoneum. It's probably time to get profiled again and see what's there. You may not have, you've got AnCan'rs saying, oh yeah, you've got a somatic BRCA mutation. You may not have that somatic BRCA mutation anymore.
Right.
And frankly, somebody like AnCan'rs knows how quickly these mutations can come and they can go. And so that's why, I mean, we went out of our way at AnCan to advocate for Medicare to cover more than one profiling in a lifetime, exactly for that reason. And we got it. It took us about a year working with FMI and some other folks, but we got it. So now that we've got it, we should be using that.
Yeah, good point.
Right. Absolutely. Okay. Peter will be listening for more progress after your next dose. So Alan Moskowitz, tell us what's up.
Sure, yeah, give an update. First, the good news. The good news is that I will finish my 1 year of Xtandi about on December 1st. The doctor let me off basically a month early. PSA has been undetectable, and frankly, I had enough of it. And so that's good. I've had my last monthly Lupron shot last week, so that it'll last a month, and I should be done with then the effects of that at least the activity of it, in middle of December. And so then we'll sit back and hopefully have a drug holiday and see how things develop. I'm optimistic that my PSA won't return to its former high of 5, hopefully for a few years, but you never know. So I'm happy for that. The bad news, which isn't directly related to the cancer, relates to the issue I had with as a follow-on to salvage radiation. I reported a number of months back that I had a bad case of hematuria with clots, leading me to the emergency room for a complete urinary blockage. Unfortunately, when I had a Botox treatment about a month ago, somehow that triggered another one of those episodes. And I ended up in the emergency room because I couldn't urinate. I was there 2 nights, partly because of timing. They couldn't get a urologist there the first night. And so, instead of clearing up, I mean, the bleeding stopped pretty quickly. The problem was the edema and all that I had. And basically, when I got home from the hospital, by the next day, I had trouble urinating. Went to my urologist. He said, just use a cold compress or a warm compress, you'd be fine. Well, I did that. It didn't help. And fortunately, and thank God, I had some catheters, which I had gotten from my urologist a few weeks before. In the event I was going to travel, I wanted to have a backup. And lo and behold, I needed that backup. And anyway, I managed through 4 or 5 days of it. And it was really a nuisance because, I had a lot of frequency of urination. I was up during the night multiple times. Sometimes I'd have to catheterize, sometimes not. And basically, I begged the doctor on the following Monday, so a week after the initial issue, to give me a Foley catheter for a week until things calmed down. And that comes with its own issues, but actually it was pleasant compared to the awful time I was having. When that was taken out, I still had to do some intermittent catheterization for, 4 or 5 days. I'm pretty good now. I'm not back to snuff. And the thinking was as they overdid the Botox, and so bladder had difficulty emptying. Even now, it's not normal, and but I'm managing, and it'll only get better. Anyway, I think probably in my case, because of the radiation cystitis that I have, probably I can think that it's probably a bad idea to do this Botox treatments. So anyway, it's been.
What's the Botox for?
I'm sorry?
Yeah, what?
Yes, I've
What's
had
the
Botox before. That's
But
what's
what
so.
is it? What is it used for?
I'm sorry, I couldn't hear that.
Alan, why are you getting Botox?
For overactive bladder that
I
was
see. Okay.
unresponsive to every other kind of treatment. And I'm beginning to come to the conclusion, actually, that some of that overactivity may be due to the radiation cystitis. And even though I had 20 sessions in the hyperbaric chamber over the summer, and even though there were less clots this time than I had back in May, obviously it's still present. The blood vessels are fragile. To the extent that Xtandi contributes to fragile blood vessels is a question mark. I think some of you may know that you can get, just from Xtandi alone, you can get some bleeding in the bladder, not necessarily to this extent, but when you put it all together, the less drugs I have in my system, the better. So anyway, I'm happy to be, more or less functional. Although I have to say the one bad thing is that my continence level has decreased. I used to be pretty good. I used to wear a pad, and only if I was exercising did I get some wetness. Now I really go through a pad a day, and I don't know whether there was some trauma to the sphincter or not. I don't know what to make of it
So
yet.
is your urologist, Alan,
Yeah.
isn't the urologist going to deal with this?
Well, yeah,
I
I
mean, it
saw
sounds
him.
like they're not dealing with it very well.
Yeah, I see him, and I have another appointment with him early next month. And we'll see where we are with it. I have to get another urologist. He's a little too far, and I don't really like him, and so it's all very complicated. But anyway, look, I've wrapped up my Kegels again, and we'll see what happens. There's not much else I can do in the short term, and in the whole scheme of things, it's an inconvenience, but not a big deal.
Alan, do you still have a prostate, or have you had surgery?
No, I had surgery, and
I
then
mean, Jimmy, do you want to weigh in?
What was that? Herb, what
Jimmy,
was
do you
that?
want to weigh in?
Yeah, I'm sorry. You mean on the AUS?
Jimmy, do you want to weigh in?
Yeah, I was aware. You talking about AUS?
Yeah.
Yeah. Well,
Yeah.
Alan, how I'm sorry, let me do call up. How bad is your incontinence?
I couldn't hear it, Jimmy. How bad is my what?
Your incontinence.
Oh, it's not terrible. It's just a slight drip. I mean, if I did some fast walking, I'd probably need to change a pad afterward if my bladder was somewhat full. But over the day, I'm only leaking. I used to leak maybe a teaspoon. Now I'm gonna guess maybe a few tablespoons. So it's not terrible.
Yeah. You're
But
you're
I'm
in the you're not in the you're in the little leagues. So
yeah,
that's okay.
exactly.
That's good.
Yeah.
But if it should become worse, then it's certainly it's been great for me, I think. But yeah, it really works. But it's for serious incontinence, really.
Yeah, I mean, part of it, there's other things, it's hard for me to compare apples to apples because I started taking a drug recently, this desmopressin, to control nighttime urination. Because I was waking up, I had too much volume of urine at night. And this works like a charm. And so, okay, if you're cutting back on your liquids and you take the drug, you can sleep through the night, generally, but then you might be urinating more during the day. And so, I'm trying to balance all these different sort of factors. That's why I say overall, I'm not complaining, and expect it'll all improve as long as the emergency room doctor didn't damage my sphincter. That's my main concern, but here it's sort of unlikely. So
Right. Well, the main thing is not to end up in the ER.
Yeah.
What did
You'll
they
find out.
attribute
Will
your
you put that name of that drug in the chat window? I'm always looking for the magic bullet for nighttime frequency.
Alan, what
Yeah,
did they
put it in the
attribute
chat
your
window.
attention to? Was it the Botox?
I'm sorry, two people talking. What was it, Peter?
What did they attribute your urinary retention bout to? Botox?
Yeah, but Botox. Yeah, he thought it was probably too high a dose, and that's his concern. It was very strange because I thought there was a blockage, and I made the guy do a cystoscopy. He said, "No, you're okay." He says you don't have enough of a squeeze in the bladder. You get some squeeze, and you sort of get urine. I'd say sort of it felt like you had blockage. Now there was blockage from edema initially after this whole initial event. But after that subsided, it does relate to not enough pressure, essentially.
So Alan,
find a
what's the
urologist.
name of the drug that you're taking?
Yeah, desmopressin.
What's the name of the drug?
DESMOPRESSIN. The tablets are generic.
Okay.
They're dirt cheap. And my God, I should have, done this years ago.
Well,
Makes all the difference.
You might want to find a urologist that'll do a procedure called urodynamics with you, where they
Yeah.
actually fill you up and they measure the pressure and they run you through a whole gamut of tests. And it's
Yes.
very
you-
valuable. Give you a peace of mind.
Yeah, I did have it before I did the Botox and before I did a few other procedures, and so I probably will do that again next year if this doesn't clear up. So yeah, it's a good thought. I hadn't given it. I wasn't thinking to do it.
any other questions for Alan? I think, it's my sense is another urologist might be a better bet for you. He doesn't sound like he's giving you overdose of Botox, and then he's not there in the ER when you need him. This
Right.
doesn't sound like a good story.
I agree. I gotta do some homework now. This is what happens,
Right.
you know.
Find somebody who's a specialist in incontinence.
Yeah, okay, that might be good too. Thank you.
Okay, we're going to move on. Dr. Jack, how are things?
Oh, thank you. So I wanted to give you a follow-up on my MRI, the hepatic area, which there was a rapid growing questionable cyst, and fortunately it turned out to be a cyst, nothing more than that, and I'm very relieved. So I felt lucky. My PSA, as I mentioned before, was very flat for 5 years, and suddenly it's taken off. It's up to the last one 2 weeks ago was 1.14, and I spoke to Belusic, and he said, "Well, it's gotten aggressive." Or I said, "Aggressive or more volume?" He said, "Probably both." I said, "Well, I'm still waiting for the Oximum read from Sloan Kettering." I sent it to them because I want to get a read from them because I've relied upon their readers. With all due respect for Sylvester, they've been with me 20 years, and it got lost, and I'm so pissed off. So Danila is searching for it. I have a receipt that they received it today and last week, but for some reason or other, he's having trouble finding it. Just as they've had trouble finding my tissue to want to do a from Stratera or Natura, where they do my genetic matching once again to see what's going on in my blood and trying to match up the DNA circulating. So things get lost a lot at Sloan Kettering in the tissue bank, and now it's getting lost in the mail. I'm getting kind of disgusted, but that's life. And otherwise, Belusic at this point is saying to me, "You got three choices: do nothing and just live with it and let it come and get you, and then treat it accordingly as time goes on, and or take intermittent ADT and 6 months on, 6 months off, and see how that feels for you, or go for the so-called cure." I question it because my PSA seems to be higher than I was hoping it would be at this point, where I was all ready to get the radiation IMRT and ADT for 6 months, and when it was hovering between 0.36 and 0.5 up until 3 months ago, and then boom. So my question to you guys is, what's the reality of IMRT when it starts getting between 1 and 2? I mean, is it virtually, or just more, are there any real benefits to going through that procedure and suffering the onslaught of all these symptoms I'm hearing about from radiation? Or am I better off just going with hormones alone intermittently? I don't know. I'm still a little confused, and I'm sort of kicking the can down the road and waiting for some light bulb to go off that's going to prompt me to say, well, here's the direction I'm going to go in. Right now, I have no real direction. Keeps me up at night trying to figure it out which way to go. And the other thing is the laboratory, the 1.12 was not a test that I ordered from Quest. It's a test that was done automatically because it was in the portal from the radiation oncologist who a month ago ordered it, and it just came up when I went to see Belusic when I had to have some blood drawn. He did a bunch of markers for me when I had this hepatic issue, and they all came back normal, as did the hepatitis stuff and everything else. My liver's fine, but the PSA showed up that I didn't even order because I usually order the same lab. And this is the first time I've ever utilized the Sylvester lab, and I just wonder if it's 20% higher at Sylvester like it is at Sloan Kettering compared to Quest. Quest lab is always 20% lower than Sloan Kettering, and I wonder if the lab, whatever methodology they use, is 20% more than it is at Quest. So I guess I can always repeat it at Quest or just continue using Sylvester.
I mean, you can't
So,
compare labs.
so
We all know
here's
that.
what you need to do, Jack, with respect to
I'm sorry?
variance. With respect to the variance, what you need to do is the next time you get a test at Sylvester, get a test on the same day from Quest.
Oh,
And then you'll know what the difference is. It
excellent.
doesn't really work if you wait a few days in between, but what we often tell people, especially if they're traveling, is get tests from two different places, very close to each other, and then you can see what the variation is. So that rather than make yourself crazy on the 20%, just get a test from both places as soon as you
No,
can. And
Thanks, Rick. I hadn't thought about that.
but
Very
Rick,
good.
I would take it to a different level. What is the difference for 20%? It's
okay,
not
it doesn't
significant.
matter, Herb. It doesn't matter to you, and it doesn't matter to me, but it matters to Jack. So why don't we put
Well,
Jack's mind to rest on
but
that
it
one?
won't. But it won't. If one is 20% higher than the other, you don't know what the real number is anyway.
No, but he needs to know the variance. It's good
What does
for
that mean,
anybody
Herb?
to do it who uses two different labs, Herb.
Yeah, but what I'm
Just
saying is we're looking at the trend.
I agree,
Right.
but if you're using two different labs and you want to get it at one place and you want to get it at another place, it's whether they're your PSA is 10 or 100 or 0.2. It's a good way to know what the difference is between the labs. Now, the issue that you're raising is, what about this level of PSA? And we can talk about that. But
I mean, I
that's a
think it's
different
the
issue to
trend.
that's a different issue to what I'm talking about. I'm just telling anybody, if you're worried about getting in two different labs, get the test in two labs very close to each other, and then you can see what the difference is. It works whatever level your PSA is at.
Right. Right. The trend is up.
So, Jack, I mean, I think Belusic is giving you appropriate advice. But the only thing I will say is as your PSA gets higher, the probability of finding something on a scan gets higher, finding something more localized, right? I mean, we know from the data that thanks to Jim that we've been talking about, as your PSA gets higher, the probability of a PSMA PET scan identifying the location is higher, right?
What is the
And
lowest high
that
that
may
they
be
can
more
possibly do?
valuable, but that may be more valuable than just irradiating the whole pelvic bed with IMRT.
Well, that's Peter Carroll's point of view, and that's the direction he's orienting me in toward, which is let's let it rise to the point where the PSMA shows up and we can at least know what we're treating. And, totally the opposite of Sloan Kettering. Let's nip it in the bud and radiate the pelvis and assume it's there when it hasn't been present. And I've had so many scans. I mean, 2 PSMA scans,
Right.
1 choline scan, 1 just recent oxygen scan. And I've had, Geez, so many total body MRIs and iodine scans and FDG scans, and I'm scanned out. I mean, I'm just
Well,
wondering
I mean,
how.
I think that the scans have all come back negative, right?
Yes,
Pretty much
yes,
negative,
totally.
which means any lesions you have are below the resolution of the technique,
What?
right? I mean,
Evidently,
the real issue for me would be you said you had FDG, and
I had
that
that.
was negative as well.
That was negative after they saw a couple of nodules in my lung last year after I had my first PSMA, and they wanted to rule out, lung cancer. So I went right to an FDG a week later, and then followed that with a 6 month later iodine CAT scan and no growth, and now a year later, no growth, no change, with
But
another PSMA, and followed that with an eximum.
so
So
what
no
about
growth.
what, Jack? What about another FDG? I mean, the only reason I'm thinking along these lines is if obviously we don't want it to be the case, but some of prostate cancers are PSMA negative,
Right, that's why I got
right?
the
We don't
eximum.
want, and that's why you got, but I think FDG is more sensitive.
It's funny, nobody even mentioned that. Even Danila didn't mention that. He only wanted that to make sure I didn't get
Well,
I
maybe,
had
well, I
autoimmune
mean,
lung cancer.
I'd run it, I mean, maybe I'm wrong, but I'd run it by Belucich. The other
I
thing is, what about have you had any blood,
Hold on that point.
or,
Hold on that point, Val. Herb. The FDG scan is not more sensitive for prostate cancer than a PSMA scan or an Axumin scan.
it's,
That's what I've been
no,
told.
I didn't, then then Axumin?
Right.
Yeah, I
It's
just
not
had
more
an eximum.
sensitive. And Axumin for prostate cancer, Axumin and PSMA scans are better than FDG scans.
That's what
Now,
everyone
they may
says.
Okay.
show different things because what shows up, I mean, that they're all looking at different things. Really, you can compare an Axumin to an FDG because both should show something similar. You can't really compare them to a PSMA unless you're concordant and all of your lesions express PSMA. But that's why we do these two scans to make sure you're concordant before you start Pylarify.
Also, and what about looking for CTCs? Has anybody done that lately?
CT what?
Looking at circulating tumor cells.
That's what I wanted to have done. I said to Belusic, they lost my tissue and they couldn't match it up with Stratera, which is that kind of a test. So I asked Belusic to run one of those. He said that he didn't see any appropriateness of that. I said, why not? He said, it's just going to cost a lot of money, and I don't know if you're going to be able, just blood alone. We have no tissue. So what do you recommend? Which particular test, and how do I go about getting it? And is it
To be
covered at all?
honest,
Or
Jack, I'm in the Peter Carroll camp. To
So
be
if it
honest
were
with you,
you, so what you're saying, Herb, is if it was you would wait. Is that what I hear
I
you
would
saying?
wait until yes.
well,
Okay.
And
So
believe me, Jack, I'm no less neurotic than you are.
so a couple of things. CDCs. I mean, basically, I think what you're saying is let's do a liquid biopsy because that's what the liquid biopsy
Right, a
works with,
liquid biopsy.
the CTCs. Now, we sort of know that if your CTC count is less than around 4, you're not going to get too much out of a liquid biopsy. You have to be above 4, and I forget what the actual measures are. 4 something per whatever the volume is, but the number is 4. I don't think you're going to see a heck of a lot on a liquid biopsy, but it doesn't stop you doing one, Jack. Medicare covers it. You can get it done through FMI or through Tempus or you know through most of these companies, not most, but several of these companies, Caris right now. But I don't think you're going to see a whole heck of a lot, and it's really going to tell you a lot more about your. If you do see it, it's going to tell you a lot more about the genetic component. It's not going to tell you what treatment you should do unless you happen to come up with a BRCA gene. So you know, I think you're shooting in the dark. Let's go back to the three alternatives that Belusic presented to you. One is IHT. One is so starting now with a little hormone therapy or some hormone therapy and stopping after 6 months. One is IMRT right now. I'm assuming that is without hormone therapy.
No. With no. IMRT
Oh,
with
hormone therapy. And the other is to let your PSA rise. I'm curious in this group of knowledgeable men what they would do if and we could actually try this out with a show of hands. We've never done this before, but we now have a little thing in the bottom on my screen. It's in the bottom right, and you can raise a hand in there if you want to speak, but I'm going to use it for a different purpose. Let's try this and see if it works.
Well, before you keep in mind that I'll be 84 next August.
Right.
Let's factor in my age.
You know, it's like that old joke, Kanahara. You're supposed to say Kanahara after it. You know the old you know that old joke.
I do.
Yeah. So first of all, let's ask who would do IHT, and just put your hands up. Who would do IHT?
Rick,
That means you've got to click that little hand react thing.
Don't we have to know his Gleason score and doubling time before we can vote?
Okay.
My doubling time's around 5 months, around 3 months now.
And
it's gone
what's
from
your
36
Gleason
months.
score?
My Gleason score 20 years ago.
Oh.
Well, I guess so, because we haven't done it. We don't know it since. But what was it originally?
My surgical Gleason score, was 3+4, and that was 2003.
Okay, so let's see if this works. It may not work, but anybody how many of you would do hormone therapy and then go off in about 6 months? Just hormone therapy. Please click the hand.
I don't have a hand.
Rick, I can't see the hand.
Oh, not everybody has a hand. Well,
just raise your hand.
Mike Yancey found a hand, and there's
just raise your hand.
Well, we can't see everybody, Herb. That's the problem with that. So there's a little hand in the bottom right-hand corner next to the record on my screen, but some of you may have a different screen. So I see Steve Ruer's got his hand up. That's one. And hold on a minute. Well, we got a few. So we've got Steve now.
Tony.
Who's going to do the counting here? Somebody's got to help me out.
It says at the top that there's 4 raised hands.
Oh, there's 4 raised hands. Thank you. Okay. Now, I'm gonna lower all those hands. Lower all hands. How many would do IMRT plus hormone therapy? We got 2, 3. Okay, well, we'll ask whoever doesn't have a hand we'll ask them to put their cameras on, and we'll count them at the end. So we've got 4 for IHT. We've got 3 right now for we got 5 right now for hormone therapy and IMRT. And how many? Yes.
It shows up in the screen on mine. Up in the top left, it shows 5 raised hands.
5.
Yeah, well, that's what I'm saying. I got it, guys. I got it. We'll come back. Now I'm up to 7. So I've got 7 who would do hormone therapy plus IMRT, and I'm going to lower all of those hands. Can we lower all of those hands? Yeah, we're going to lower all of those hands. And now, who would just let their PSA rise? I'm going to put my hand up there. And we got 4. Anybody else? And I see Jim Marshall has his hand up, so that's a 5 and a 6 and a 7 for Peter Kafka, and an 8 from Herb.
And Russ is 9, and Jim
Russ
Marshall
is 9.
10, and Al Latimer is 10.
No, I've counted them. One captain here, please. Otherwise, we're going to get very confused. Okay. So we've got 5, 6, 7, 8, 9. Any other hands? Anybody who wasn't able to vote can raise their hand. And we got some people who haven't voted at all because they just don't know. All right. Anybody?
Can we vote twice?
No, you can't vote twice. Who was that? Was that Sam Friedman? Who's causing the trouble here?
Only in Chicago.
Was that Jimmy? Who's causing the trouble? It's probably Jimmy. We've never done this before. We might try this again because it's kind of fun. But I feel that it looks like the more people, almost twice as many people would let their PSA rise. Now, the question for you, Jack, is, well, is it effective if I allow my PSA to get that high? That's your concern. In the old days, they used to wait until your PSA got up to 10 before they jumped in. So,
Rick, I think there's a couple of variables that need to be taken into consideration.
One at a time. Tony Fig, go ahead, and then we'll come to Dr. Jack.
I think there's some variables that need to be taken into consideration. I had a liquid biopsy done for circulating tumor cells for 3 years. They remained pretty much consistent between 2.1 and 2.3. And I was diagnosed in 2018. Initially, it was in one quadrant. And for 3 years, I felt rather comfortable with the low CTC numbers. However, I had a biopsy done and it had spread to 4 quadrants and became very aggressive. So in my decision to go ahead with hormone therapy and not let the PSA rise, I was taking into consideration how aggressive it was. So I did a DNA test and it came back with a mutation, but also a Decipher test came back for the genomics as 1.0. So my consideration was, do I let it rise and metastasize to other places in the process of letting it rise? It was all contained in the prostate, but the pathology came back at a Gleason 9, 5.4. So, I took that all into consideration before.
Right.
So Jack I don't know if he's familiar or knows what any variations he has.
Yeah, but Tony, that's why we asked him before you all voted, what's his Gleason? And it was 3+4. And Gleason's probably don't change once we've taken it out of the prostate. So he was never a 4+5. 4+5, there's different considerations.
Right, exactly. That's
why Herb asked the question. So, yeah, I mean, but granted, what was your vote, by the way, Tony? What did you think Jack should do?
I accidentally voted twice. I decided to do the hormone therapy plus the radiation.
I mean,
so if you were Jack, is that what you would do now, with Jack being a 3+4 and a 1.14 PSA?
Or 2.
Or 2.
I don't know. I think Jack. So I want to hear now that we've got this poll, and Jack, you've heard the common wisdom of this crew, what do you think?
Well, the common wisdom, corroborates Peter Carroll and Belusic, which both say ride it out. Belusic pushes the ride it out ad infinitum much more than Peter Carroll, who says let's ride it out and get another, PSMA scan so we know what we're dealing with. Belusic says, just ride it out, and when your PSA gets around 7.5, you'll probably metastasize, and we'll treat it accordingly. So I don't know where he got that figure. 7.5 sounds a little arbitrary, but maybe you guys know what that means. I don't know. I didn't realize that there's a certain threshold you go over where it's a fait accompli that it's going to metastasize, to the bones or wherever.
No, I don't think that's true. It may
Holy
be
shit.
so. Here's the thing, Jack. It might just be oligometastatic. It may pick up 2 or 3 mets as it gets to be detectable. In which case, therefore, it might even be treatable. And this is their recent papers talk about this. Just treat it with very localized SBRT, spot radiation, rather than the whole idea of radiating your pelvic bed and giving you hormone treatment, which is, and you're feeling fine. I guess I find that hard to accept.
I agree. I agree 100%, which is why I keep fishing and going scan after scan after scan after so many scans, because I want to go and hope that I can spot it and treat it accordingly rather than blast my kishkis. I mean, Jesus, I mean, I have a friend of mine who's my age who just went through this, and he almost died. And I'm listening to the guy. He stopped the ADT, and he's walking around like a cripple now after going through 37 radiations here in Miami. And he still has a prostate, but he was a 5.4 and had no choice.
Why do I step away when all the excitement starts? I tell you.
Well, the votes are in. It's all decided.
So look, Jack, I'm afraid we probably should move on tonight.
Thank you, guys. As always, I appreciate
I think,
it. Thank you.
I'm willing to talk privately about this anytime you want. I mean,
I don't want to extend it out too much more, but all we've talked about is the medical end of it. And I know where Jack's kind of at. I mean, I finally decided what I'm going to do, and I feel much better now that I've decided what I'm going to do. May not be the right thing, but I mean, none of you can, you're talking odds. None of you can say, yeah, this is the right thing to do, and no, this one's the right thing to do, and that one's the right thing to do. It doesn't always work out exactly, and your emotional state's really important too, along with your physical.
You're right, Norm. You're right. I'll vouch for that as practicing psychiatrist for 40 years.
Yeah. So I just want to flip a coin, make a decision, and just do it, and just like,
I'm hoping
I have to throw this in. You know what they told me? They said, you are young, you are healthy, you look good, all your numbers are good, you're an athlete. We're going to throw everything at you because you can handle it.
That's right.
And I guess I did.
Well, they thought that for me. That's what they thought for me, but I couldn't handle it.
Oh man, I'm telling you.
I handled it, but I got a few bullet holes in the side for sure.
Anyway, so Jack, we're with you on this.
Thank you, Herb.
But please
Thank you, Rick.
make a decision and send us a code. So let us know what you're going to do.
I can't guarantee. I'll have to speak to some people before I make a decision.
Right.
I'm getting there. Thanks, guys.
Okay. Julian, you're up.
Well, I had my blood work done last week, and I had an early call with Dr. E this morning, my medical oncologist, and she has said, stop taking all that Orgovyx and Nubeqa, so I'm off of it as of today. So she said, I'll see you in 3 months. Thank you. Bye. So my PSA has been in the dirt well over a year. And she did something called ultra sensitive PSA, and it still was in the dirt. So she said, let's stop.
Good for you. Save up those Nubeqas for people who need them.
Oh, I have a bunch of Orgovyx, by the way.
Okay. Any
And
comments, Peter?
we
You know,
should have an
you guys,
auction.
right?
That's interesting for me. I'm on Orgovix. I just had blood work a couple of days ago. Testosterone undetectable, PSA undetectable, and I'm seeing Dr. E tomorrow. Would love to hear the same thing.
How long have
How
you
long
been
has
on?
your PSA?
How long have you been on the treatment, James?
Been on Orgovix since February of this year, so
Right.
not that long.
I think that to hear that you need to have been on a little bit longer, because don't get your hopes up,
I know.
because you need a real base in that, and if you've persevered 18 months, something like that, then that's the time that a good GU med onc is going to say, okay, you're right for that now. But don't base what your expectations on Julian's.
Yeah, yeah.
Yeah, I know.
But,
I know.
yeah, he
That's more
told me when
just
I saw her,
wishful thinking on my part.
yeah. Well, no, it's good thinking, but have a hope. But
But hopefully
she
you'll
told
get
me
there.
she was going to stop it in February, but she made a decision today to stop it.
So how long were you on it?
Well, I was on meds for almost 2 years, and then I got switched off. Do we have time for my story?
Yes.
Well, short version.
Short version, I had DMAT, which is the version IMRT, and it dropped my PSA real fast. And then I went on, and this was over 2 years ago now. And then I went on ADT with Lupron and Abby. And then when I started gaining weight, Dr. E switched me over to Orgovix and the Nubeca, and I was on that for about 6 months, 7 months. And she said, that's enough, because my PSA all that time was in the dirt. So it's been about 15 months that PSA's been in the dirt.
Okay. Okay, thank you. I don't want
That's
to
great.
take any more time. That's very good news. Yeah.
Yeah.
And
Well,
you'll
James,
get
we'll be
there.
hearing.
Yeah,
You'll get there, but we'll hear about. You'll tell us what's going on next week or 2 weeks. 2 weeks. We don't meet next week, right?
That's right. Good one for getting that in, guys. There's no meeting next week. It's a 5th week, and so we don't have a meeting. So our next meeting is going to be the first week of December.
Okay. So let's move on. Norm Pollock, tell us what's up.
Oh, I want to update you on my wife. She did great with her surgery. She had the deep brain stimulus. She had the electrodes placed. They couldn't find the doc. The doc was in surgery, and then the resident had to go somewhere, and they couldn't get her out. She got up, she got dressed, and she stood out in the hall tapping her foot. And they went, "Okay, we'll get you out of here." She said, "I'm walking," and they walked her out of the hospital after drilling her head 12 hours before. So, it was pretty amazing, and she's been on her honeymoon and doing great. It's wonderful. And I got approved for the darolutamide today through Bayer, and which was nice. And I also found out that the guy at UT for radiation therapy, who was referring me out about 20 minutes closer, I found out they have one 18 minutes away from me instead of driving an hour and 10 minutes each way every day. So I'm going there next Tuesday. So that's all my good news.
Okay. Well, that's great. So what about your wife's symptoms?
Well, she gets her controller implanted this Wednesday. There's a honeymoon period they think it's from the brain swelling.
Right, edema.
She's had very few tremors. She's like when she first got diagnosed. She's walking real well. She's really happy. So we're hoping that might be a sign of how well it's going to work. Don't know. We'll see.
Good. Let's hope so. Great. Thank you. Robert G., how are things?
Hi, things are going okay. So I'm early on my path, a lot earlier than most of the folks here. So after months of research and several tests, looks like we'll be starting with, I'm going to be going with radiation for my initial treatment, and starting with Firmagon Wednesday for 2 months, and then we'll get to the IMRT radiation. And docs want me on the Firmagon probably probably for about 2 years, and then after radiation they want to add let's see if I can remember the name of it. Zytiga. So just an update of been here a couple times, over the last month and a half or so, and lots of delays in my diagnosis and testing. A bout of COVID within our household earlier this month, which for my wife and I was the first time. So, but now we're kind of bounced back from that, and I'll start on my treatment. So fascinating listening to what folks are going, how folks are going with these days, and future things should they become necessary. I'm hoping a lot of what you guys talk about tonight won't be necessary, but I know statistically
Right. So,
they
Doc,
may
so
be.
what's your current PSA? Doc,
Last
what's your
PS
current PSA?
last PSA was 8.8 is kind of how the
Okay.
doc adjusted it. It was actually lower, but because I'm on finasteride, he said that tends to cut it in half. So it's like a 4.4 was the official PSA, but he said that's really equivalent to an 8.8 or a 9.
Okay.
So I have a couple of
Thank you.
things,
Any
Rob.
questions?
Yeah, I have a couple of things. First of all, be sure to get your testosterone tested before that first Firmagon shot. When was the last time you had your testosterone tested?
A little less than a month ago.
Oh, okay. And what was it?
I don't know. I have it somewhere. I know they did it. They ordered labs and testosterone test, and
Well, it wouldn't hurt if they don't object. Get a baseline testosterone right before you get your Firmagon. It will be very helpful later. Okay. Secondly, what type of radiation are you getting?
IMRT. Are there multiple flavors of that?
Well, there are, and this is and how many treatments are they recommending, Rob?
I believe he said 5 weeks.
Yeah,
5 weeks.
37.
Yeah, it's usually between 37 to 40. The reason I'm raising it is this. Hopefully, are they radiating your pelvic girdle?
Because the MRI, because from the biopsy, they did 12 cores, all 12 were positive, and the MRI kind of shows the cancer right up on the edges of, I can't remember the words, but on the up to the edges or margins of the prostate. There was a flagged lymph node which the PSMA did not indicate was cancerous, but the radiation oncologists and medical oncologists both believe there's a high likelihood that there is cancer beyond the prostate, in that area. So the radiation oncologist was going to target the lymph nodes anyway.
Okay.
Because
Are they going
2
to
lymph nodes are
radiate the
flagged.
whole prostate girdle?
That I don't know. I hadn't heard that
Okay, so
term before.
you must ask them. I would say if it were me, I'd absolutely want that whole prostate that whole pelvic girdle radiated. With your disease demographics and what they already see, if it were me, I'd be asking for that. And if they're not going to do it, you should get a second opinion. So now, you can cut the amount of radiation visits down by some 15 visits by getting the gland radiated with SBRT. So the numbers don't show any difference, but if you get SBRT to the gland, they can do that in 4, maximum 5, whereas they're probably going to take about 17 to 20 if they do it with IMRT. And the problem is that a lot of places won't talk about it because they don't do it.
Okay.
And now you've got time because you're going to start the Firmagon and then we're going to wait to weaken the cells. But if it were me, I would be asking about SBRT to the gland and full pelvic radiation for the balance. And that's pretty much optimal.
And why is that, Rick? Is that in order to have fewer trips to the radiation center?
Yes. I mean,
Yeah,
basically,
okay.
yes. I mean, there's
Yeah.
not a lot of, there's not, I mean, and it's been compared, there's no downside. You know, what we generally tell folks nowadays is if you can get SBRT, get the SBRT. It's a much easier process. And then, but they cannot do, I shouldn't say they cannot do, but they haven't perfected doing SBRT across the pelvic girdle yet. Norm
Well, it's
Pollock,
also,
was that you holding up the caution sign? What are you cautioning us for?
I forgot to send. I didn't get a chance to send the sheets to Lynn that we were talking about last week with the drugs, the Orcovix and the darolutamide, and how bad they were. And that's what that bag that the Orcovix came in. It says caution,
Oh, okay.
hazardous.
So hold on. Does it have something to do with this conversation? Does the caution you just held up have something to do with this conversation?
No, I'm sorry. I shouldn't have done that. I was just trying to show Lynn
Okay.
real
So
quick.
let's put
I
you back on.
apologize.
Okay,
That's from
just put
last.
you
That's
back on
from
one
last
side.
but Rick,
week.
so I mean, Rick, the whole point of SBRT is it's much more precise. They use a much closer fitting model. The radiation spills over much less because of the way they can focus the beam
Right.
with SBRT. So you get a much more intense radiation to your prostate and less radiation to the area around the prostate. You don't want your rear end radiated and you don't want your bladder radiated. And that's the advantage of SBRT. So I'm with Rick on this one, that if you could just have them do SBRT to your prostate, much less risk of side effects than IMRT. And that's
Yeah,
been shown by many clinical studies.
so they can do the SBRT. Sorry.
I was just going to say I had SBRT based on joining this group because I was this far away from getting surgery, and I'm ecstatic that I went the SBRT route. It was quick, it was easy, and I had 0 side effects, and I've had 0 incontinence.
So for me, the suggestion of the SBRT, the concerns I had is one is that the prostate cancer appears to be spread throughout the prostate and up against the margins on both sides. So it's not one spot within the gland.
No,
And
but
then there was the issue that
nevertheless,
they
they
wanted
can
to
aim
also
it.
look at beyond beyond the prostate.
Okay,
So
so
They can
that's why the
the
add
radiation
SBRT,
oncologist.
the
Sorry?
SBRT to ablate all of the gland is not an issue. If they're telling you it's an issue, it's because they don't have the equipment. The IMRT is going to take care of everything outside the gland, and that you can continue to do with them. But there's no good reason for them not to do SBRT unless they don't have the equipment and they want to get your business.
They do. I mean, they advertise it. They call it CyberKnife at this place.
Well,
Then
if they have a
if they
cyber knife, that's what you want.
right, if they've got CyberKnife, they should be giving you CyberKnife to the gland, and the boost should be to the whole pelvic girdle, and that is the standard of care. And we've got loads of articles that we could send you, and if they're not familiar with that, we can send it. You come back to us. They should know that that's today is the standard of care, not 37 treatments of IMRT anymore.
Okay, yeah. Well, I was thinking 5 weeks is positive because when I was researching it, I saw 5 to 8 weeks.
I think.
Well, let me just say this: 5 weeks may be SBRT to the gland, because SBRT to the gland is it's 5 treatments are approved, but you can do it in 4. So some docs do it in 4, some do it in 5. And then you've probably got 20 IMRT, which is another 4 weeks. So altogether, that makes 5 weeks. So it may be they are giving you. So it may be
No,
that.
he was pretty specific that it was IMRT. So
Well,
IMRT
I
plus.
don't see that. I mean, 5 weeks of IMRT is 25 treatments. That's not enough.
Yeah, that would take 7 weeks or
7,
8
right.
even.
Yeah.
So I think, given you have time to ask, Robert, I think you should really have a conversation and say, with this radiation oncologist, and say, can we do SBRT to the prostate and then use IMRT to cover the rest?
And make sure
So
the rest is all the pelvic girdle, not just the rabbit ears pattern that some of them do.
Right. And how many gray each session? And how many total gray? Gray is the measure of radiation.
what is that called?
Gray is a unit of radiation.
Okay.
How many gray to the prostate? Usually it's like 35 gray. And then how many gray to the pelvic girdle?
So even though none of the tests show that it has gone beyond the prostate, you still think that this is the
That's
way.
right.
Yeah.
Okay, because
Well, this
it's
is
a
what
Gleason
just
9,
heard
it's a
this.
high likelihood.
Yes.
Yeah,
And that,
Gleason
look,
9. Yes.
let me talk about my case. Okay. I was a 4+4, and I got seeds to the prostate, which is the equivalent of the SBRT. And then I had 22 or 23 applications across my pelvic girdle, because they already thought that there was that the disease was in the prostate bed. But this is how they treat. If there's suspicion it's already outside and you're a 5+4, they should be radiating the whole pelvic girdle. Some of them don't. And I got to tell you, the number of people we've seen come back because they didn't get enough radiation in the first place is a lot. And if they are saying that they're reluctant to give you that, then I would say you need to get a second opinion as to where you're going to get treated for your radiation. Because that is I mean, there's enough evidence now that if you have a 4+5, 4+4, and certainly a 4+5 or a 5+4, that is the gold standard of care.
So please have this conversation with your radiation oncologist in the next 2 weeks, and then we'll talk about it in 2 weeks.
Yeah, I'll try that. I mean, it's a holiday week, so I'm not sure I'll be able to get in that short a time, and it's a 4 hour drive.
Well, they won't do telemedicine?
Oh, they'll probably do telemedicine for this one, for this.
You're
Yeah.
just asking a question. You're not going for treatment.
Good point.
Where are you planning on getting the radiation? Local to you, or are you going to have to go stay up in Denver for 5 weeks or 7
It's
weeks?
it's Penrose Cancer Center. I can't remember the other name they use. I think they also go by St. Francis, but Penrose Cancer Center in Colorado Springs.
Okay, and that's the 4-hour drive. Is that right?
Yes.
So,
Yeah. Well, actually, it's closer to 3.5 to get there.
okay. So, certainly for somebody like you want to minimize the number of visits. So right away, you want to be sure they're doing the
Well,
SBRT to the gland.
if I'm going up there, I'll probably be staying during the week,
Okay.
because going
So,
back and forth over a mountain pass in the wintertime on a regular
okay.
basis
So
is not really
Right.
going to happen.
let for the sake of speed here, let's sort of we've got it.
Yeah.
Right.
The issue
I think
is that you've got to get the right setup, and I'm not convinced this Penrose Cancer Center is giving you the right setup, and you may want to get another opinion on radiation from University of Colorado from whatever it's called. I forget the name of the cancer center there in
AnCan'rs, is it at
AnCan'rs,
AnCan'rs?
yeah, that's where my urologist is.
So,
well,
but anyway, I'd like to, I think, Robert, I think you want to get this nailed before they start. So first, I'd talk to the local guys, and then if you have to get a second opinion. Okay,
We'll go down
any
that
other
path.
questions?
But it's still ADT, or the Firmagon to start, though,
Right,
regardless.
for sure.
Okay.
Right, you need that for sure.
The host country for the World Cup this year. So they say, quote, welcome.
Larry, we need a muter. Okay, we have a few more minutes. Roger, are you new to this group? Roger? Oops. Roger is not there. Joel, you put something in the chat window. Would you like to give us an update?
Yes, I would. Can you hear me?
Yes.
Okay, great. Yeah, I talked to Dr. E today, and she just informed me in a quick statement that she had just returned from Canada yesterday, and she had lectured up there, presented some data about the Aussies comparison of the FDG PET scan to the PSMA, but she didn't elaborate beyond that. So I didn't even know she was in Canada. So if anybody knows something about that, let me know. I'd like to get that lecture. She reviewed all my blood tests. She said that the only thing she was disturbed about is my phosphorus was elevated. I've never had phosphorus elevated before. Does anybody know what that means?
Well, it could mean bone activity.
Okay. All right. So if the cancer is being killed.
Calcium phosphate is bone.
Okay. All right. So she wasn't too concerned to do anything about it, but she says we need to watch this carefully. She said she had got some returns on the liquid biopsy from Tempus, the other Foundation One Medicine and Caris Life Sciences and Garden 360 organization that's in California. And she said, I probably have a BRCA1 gene. Uh, So, but she said, I don't have the full report yet. We'll talk about this later, which is something new. None of the other, I had 4 tests already, 2 genetic tests and 2, 1 tissue test and 1 blood test from Foundation One Medicine, and none of them found that. My PSA, however, has gone from 1.5 to 0.6. And she says that's on par with where you should be. She says, when I talk to you again in 2 months, I expect it to be undetectable.
Wow. Wonderful.
So that's basically the latest. She is vibrant and pleasant to talk to, as all the other guys know. And I did ask her, am I on a short course of Orgovyx? And she says probably so, but we'll see how your numbers go. And I said, well, probably the same thing with darolutamide. She says, yep, that's right. We'll have to see how your numbers go. So I was glad to hear the 2 guys tonight saying she canceled their Orgovyx and their darolutamide, because I'm hoping that'll happen to me too.
Good. It seems like she's the place to go if you want to head your PSA head to 0.
Yep. I've been very pleased with her so far. She says, I want to see you back here in February because I'm going to give you an FDG PET scan and a PSMA PET scan on the same day. And we're going to compare the 2. And if you have any lesions on the FDG, it means you have your aggressive cancer genes are at work. And he says, if they're the same, then I won't have to worry about it for a while.
Okay. Well, more positivity from Dr. E.
Yes.
That's for sure. Okay. Talking about Dr. E, James Davidson, you came late, but did you have any updates other than what you told us from Dr. E?
I do not. Like I say, I'm seeing her tomorrow. Just did a round of labs. I'll have something to report next time.
Okay. Well,
Thank
we
you.
actually made it in less than 2 hours.
I'm very curious why she would be suspecting a BRCA mutation, a somatic BRCA mutation, but she can't confirm it. I mean, to our brains trust, what could that, what would
It's
make us suspect?
a preliminary report that she didn't see the whole thing. That she didn't.
Also, BRCA1 is very unusual in prostate cancer. It's usually BRCA2.
Right.
In breast cancer, for women, it's BRCA1. Very low, I think it's single-digit percentage of BRCA1 in prostate cancer, for whatever that's worth.
As an aside, she also asked me how old my son was. I said he's 47. She says, I want him to take an MRI of the prostate. I said, well, he's been monitoring his PSA since he was 40. But she said, no, with this data in front of me, I need to have him do an MRI of his prostate at 47. So she's suspecting something. She didn't elaborate any further than that.
She's really right on the ball.
I think so, yes.
Okay.
She also said that Rick and her should hold a consortium together every year to compare notes with his body of gentlemen and her knowledge and so on. So she said that the first time I saw her in Houston.
Well, guys, I just a quick preview that she has committed to spend time with the group. I think it's on the 17th of December, if that's a Monday. I don't know. I'm wrestling with my calendar here. No, the 19th. So I think she's going to come into the group on the 19th. She wants to chat with you. You may want to chat with her. So we'll be advertising that once we get into December. And of course, with knowing her, something could come up. She's got to go somewhere, but we'll do it. But but she's going to come flirt with all you guys.
Okay.
So
So my update is tomorrow I get my next Lupron shot at 8 in the morning. So that's keeping me around. I'll get another PSA number from NIH to compare to the Hopkins number.
So I always found for me that it was good to exercise after I got my shot. So you may want to come back and hop on your bike after you get the Lupron shot.
Rick, I've been having so much pain. I have to talk about that another time. So
Okay.
anyhow, but yes, I agree.
Okay.
Anyhow, guys, I
I
think
don't
anybody
see Don
else?
Kramer. Yeah, with Don Kramer,
He
but I
left. Don Kramer left. So anybody else want to add something? Otherwise, I wish you all a happy Thanksgiving.
Same to you,
Where's
everyone.
your pain, Herb? Herb, where's your pain? Is
Leg,
it local?
back
Happy
pain,
Thanksgiving.
back and hip pain.
Just curious, has anybody noticed that hospitals are starting to look for more inpatient visits than starting to schedule
So it's sort of been bothering me a lot lately.
Okay, two people talking.
Thanksgiving,
First
guys.
of all, hold on a second, guys. Larry had a question, and Herb was responding to the question, "Where's your pain?" And the pain is in Herb's lower back, right, Herb?
And hips.
And hips. So, any comment on that? Whoever asked.
Well, I was just, we do a lot of complementary medicine. My wife uses, and I've been using them for strains and sprains and back pain. It's called red light therapy, and they have all these pads. They made her bowels start moving, and they're not sure why this red light therapy works, but to us it works. She would have a bowel movement once every 3-4 days, because that's one of the things with Parkinson's. When she uses her red light therapy twice a day on her stomach, she has a bowel movement every day. And she quit doing it while she was doing the surgery, and she's back to using it again and trying to get things moving again. And they're great for pain. They work. I mean, it's not 100% cure all, but for a couple $100, it'll relieve a lot of pain.
Herb, do you think the pain is related to your prostate cancer?
Well, that's what we're not sure about. That's where I've been seeing 3 different docs. Nobody can give me a definitive answer. I did a CAT scan which showed pelvic girdle cancer, hip all around, but again, it couldn't say whether they were active lesions or old lesions because they didn't have a comparative scan. So I don't think it taught us very much. The scan didn't help much because we know I have cancer. So, and I have spinal stenosis. So the next step is I've got an appointment with a different physical medicine doc recommended at Hopkins, who supposedly maybe can tease this apart. Because I don't know. We don't know if it's related to spinal stenosis. We don't know if it's arthritis, because everybody has arthritis at my age, or cancer. But I can say that it's up until now, it's been responding to ibuprofen. But the last couple of days, it's sort of peaked. So it's a puzzlement.
Right. I've also had a hip replacement, which obviously a symptom of that was significant hip and back pain. So just throwing
Right,
it out there.
but the X-ray that the orthopod took said you're not ready for a hip replacement.
You got that covered then.
So it's sort of like, that's why I'm so confused. I said orthopod, physical medicine, cancer, who knows? So that's
My
hopefully,
left. Go ahead.
I'm listening.
Oh, my left hip. The X-ray from the guy who did my right hip goes, "You're not going to need a hip." He said, "You're fine, but I want to get an MRI." Got the MRI. He says, "No." He says, "The backside's all eaten away." But they can't tell by a straight X-ray. And it felt much better after I got a new hip.
Herb, what do your blood chemistry show? Your alkaline phosphatase and your calcium?
Well,
What
yeah,
about?
they're not that high. They're all kind of reasonably they're high because of the metastatic disease, right? But not terrible. 60s. They're not like showing massive bone activity. I mean, I look at ALK-Phos a lot.
For what it's worth, my guess is with Herb that this is more related to hip and lower spine arthritis, and that's just not medical advice. It's just my guess from what he's been saying and the response he's been getting, and that's what we're really hoping for. Let's go to the Larry Fish. We'll come back. Larry Fish, you had a question for whoever. What was your
Compared to
question?
compared to Herb's pain, this is so insignificant. It was just a random thought that I've been having. Uh, do people feel like they're getting more requests for coming in person to visits than over the last few years? It just seems like televisits work pretty well in general, but all of a sudden, doctors starting to want me to come in for visits. Wonder if that's just something that other people are noticing. That's not an important question compared to.
Well, it's a good question. Any feedback? We should ask that question next week, and in 2 weeks when we got a full. Put that question. Keep that question for 2 weeks, and then we can have another interactive session with the hands up and down. There you go, Larry. It's a
Right.
good question for the hands up and the hands down. Because
And the other part of it is, I do have to say one thing. The pain seems to be worse when I go to the gym. After the couple of days after the gym.
Yeah, which is why I think
And
it's
even though I
arthritic.
try to,
I think it's arthritic pain. I think it's muscular and arthritic pain, and I think that's where the adjustment is. That's why I said that, that's one of the clues.
so then I should go to a rheumatologist.
Well, I mean, I think that you've got to try and get a diagnosis first, and the physical medicine guy is probably as good a place as any to start.
Right.
Some rheumatologists aren't going to be much better than, I think the physical medicine guys are a very good place to start.
Actually, it's a she, but that's okay.
Okay, well then, you'll go see her. And then the other thing is to start adjusting some of your exercise schedule and seeing if you do certain things, it gives you more pain. You do certain things, it gives you less pain.
Right.
Okay, face it, Herb. Here we are, all old guys. You have joined us.
No shit.
Thank you, Captain.
Thank you very much.
I was going to suggest he goes to the genie and wishes to be a little bit younger to get rid of his pain.
That's right. And you could be careful what you say, Captain Marshall. You could be offending Jim Barnes. You could be offending James Davidson here. We're not all old guys. There are some younger guys, and Dennis McGuire.
Yeah.
Oh my gosh, Dennis McGuire, the baby of the group.
And Robert's young.
And Robert's still with us. Yeah, I think
Yeah,
you're
but
gonna have.
I've been
But the
experiencing
point is,
I'm experiencing some of the pain that Herb's been talking about.
But the problem is that they're all going to get to our stage eventually.
The mind is young and the body ages.
Right. Right. Exactly.
But it is
Okay.
Anyway,
scary with
guys,
those aches and I say it's scary with those aches and pains going. Is that more or is it just something else? Yeah.
You're
I
not
don't
using a
know.
cane or anything like that, Herb, are you?
No, I don't need a cane. My walking is not great, but I'm not at that stage yet.
I mean, I was at that stage when I got my hip replacement. It was horrible. The pain was horrible.
Right.
So
I mean, right now I have to tell you guys, I took Motrin before the meeting. I'm sitting here. I'm not feeling any pain sitting. So
good.
that's a machaya.
That means it's a very good thing.
Right.
All right,
It
guys,
is.
that's it.
Good
And
night. Happy
Good night.
Thanksgiving. Don't
Dr. Jack,
Thanksgiving.
in future, Dr. Jack has to do the Yiddish translations. I'm not doing them
right.
anymore. Okay?
Which one?
All right.
Messiah?
Have a l'chaim for the l'chaim.
Right. Don't eat too much turkey.
Yeah,
All right,
easy on the turkey, guys. We'll see you in 2 weeks.
Good
Goodbye.
night.
Bye.
Bye.
This conference